So it's 4 p.m. Italian time, so it's a great time to get started with a great project, which is the acronym of Graduating Residents Enhancing Active Teaching. Of course, we look forward for being all together in Dubai for the Universal Expo and the winter meeting when we will connect experts to properly inform patients. And now the countdown has started, so we look forward for being finally in person again together, but let's keep on enjoying some online educational activities. When we will be in Dubai, we will enjoy more than 190 countries with the different nations pavilions, and we are indeed here seeing the 3 ones related to the 3 nations of which we are providing a simultaneous translation in. So we will have Russian, Spanish, and English translation together with also international CME credits. So remember to choose the language you prefer in the interpretation button. Remember, you can make questions in whatever language. They will be answered live if time allows, if not in the following day by mail. Remember to do that in the question and answer box so we can see them, not in the chat. You can reach out to the organizing secretary for the International CME Credits Certificate. And as I was saying, we really look forward for going on with this great adventure as per the acronym, because indeed we are trying to accomplish together 2 missions. One is the audience engagement, for which today we will enjoy another contribution from the evidence-based comments we received from the audience, because indeed with the online activities we have noticed that we unfortunately lost some of the great contribution we usually enjoyed from the audience in the live meetings. And the other big mission will be the one of engaging residents. I truly like this drawing that is saying, I suspect we will find the coffin painter in the last one, and the coffin of course is not like so properly designed. So residents are the present and the future, and today they are the present in representation with these 5 great residents who have been selected to co-work with the 12 top mentors and 25 key opinion leaders from all the continents to co-work together on another usually under considered topic, that is chronic venous disease and peripheral arterial disease coexistence in the same patients, and how to properly manage these patients of ours. I'd like to deeply thank the stellar faculty who started this great project last week, and to deeply thank the ones involved today. We will introduce them one by one. Nothing would have been possible without the unbiased support of Mehdi, who I particularly thank for having allowed us to engage in the first line the residents. Nothing, as always, would have been possible without the friendship and the family feeling and great teamwork with Professor Bottini and Professor Ci. So I will pass now the mic to Professor Bottini.
Sergio, and really welcome everybody to this great project for young professionals, sharing science with the stellar experts from all over the world. Remember, Spanish speakers can make questions in Spanish, waiting them in the question and answer box.
Thank you so much, Oscar. Willie?
Thank you very much. Good to see all my friends and colleagues. Good morning, good afternoon, good evening. If you have any questions, even in Chinese, please write them in the Q&A box and I will try to translate.
Thank you so much. And it's early morning in Phoenix, from where we are welcoming with a huge pleasure and honor Professor Peter Golovinsky, who definitely needs no introduction. As you know, we usually have a 1-minute opening remark from a huge figure from our venous and also, of course, arterial ward. So we pass now the mic to Professor Golovinsky. We can see your slides perfectly.
Wonderful. Good morning and good afternoon, everybody around the world. Greetings from Mayo Clinic in Scottsdale, Arizona. It is a distinct honor to be the guest of honor of this excellent idea and great seminar. As you know well, the lower extremity vascular disease involves arteries, veins, and lymphatics. And today they are equal partners. Diseases of the arteries are as important as diseases of the veins and diseases of the lymphatics. And the Journal of Vascular Surgery recognized that many years ago when we established a separate journal to arterial disease, separate one to venous and lymphatic disorders. And many data in the discussions you are going to hear today are based on scientific evidence, on the arterial circulation that we published in the Journal of Vascular Surgery. We also have obviously a lot of evidence-based guidelines that were published all around the world previously, but also consult the latest excellent updates and papers that we published in the venous and lymphatic JVS. So with this brief introduction, I wish you real good luck and great experience today with this great project.
Thank you so much. Thank you so much, Professor Glowinski. And since these webinars are involving residents in first line, I really suggest you to enjoy the great educational contribution of JVS. Should be your holy reading at the next of your bed every day to really move forward in the discipline. And there are like different opportunities to enjoy that also on the social channels. So make sure you check for JVS also on the social networks. And now let's get started with the real scientific efforts that have been done indeed in collaboration with the two mentors that in this case are Professor Josnen from the French Society of Phlebology and Professor Narayan from Singapore. As you know, the design of the project is to have a speaker as a brilliant resident will be Thomas James, vascular surgery resident from Toulouse University, will be talking about peripheral arterial disease diagnosis, all venous specialists should know. And after that, we will enjoy the contribution of the mentors.
Hello, my dear colleagues. My name is Thomas Jam, and I'm going to speak about peripheral arterial disease diagnosis. Peripheral arterial disease, PAD, is a chronic occlusive disease of the lower limbs caused by atherosclerosis, which is responsible for a lack of perfusion of the downstream territories. Patients with PAD are at higher risk of major adverse cardiovascular events like cardiovascular death, myocardial infarction, and stroke, and are also at increased risk of all-cause mortality and amputation. The prevalence of PAD increases with age to reach about 7% before 50 years old and between 15 and 20% after 80 years old. Two main clinical classifications of PAD exist: Fontaine classification and Rutherford classification. For practical purposes, it is more effective to distinguish three classes: asymptomatic stage, which concerns up to 50% of the patients with PAD; lower extremity pain on exertion, claudication, which concerns up to 45% of the patients with PAD. These patients are at high cardiovascular risk but a very low risk of amputation, less than 5% at 5 years. The last stage is critical limb ischemia, CLI, with rest pain and or ulceration, which concerns less than 5% of the patients with PAD. These patients are at high cardiovascular risk and also have a very high risk of amputation, 30% at 6 months. Examination is based on the assessment of medical history for claudication and ischemic rest pain, but also for coronary arterial disease and cerebrovascular disease. On physical examination, we have to research abnormal lower extremity pulse, vascular breath, pallor, coldness of the limb, non-healing lower extremity wound, and gangrene. The absence of the posterior tibial pulse is more accurate for diagnosis of PAD than the absence of the dorsalis pedis pulse, since the latter is not present in up to 20% of healthy subjects. For the diagnosis, do not limit yourself to the medical history or the physical examination, because the patient may be asymptomatic, since only 10% of patients with PAD present typical symptoms. This is why the standardized diagnosis is made on the ankle brachial index, ABI, which is a functional index. ABI is a simple tool that is non-invasive and inexpensive. The association between low ABI values and an increased risk of cardiovascular events has been described in several population-based studies. But how to measure it? After a 5 to 10 minutes rest in supine position. The cuff is positioned first on the right arm, then on the right ankle, then on the left ankle, then on the left arm. A final measure is taken on the right arm again in order to avoid the white coat effect. The systolic blood pressure is measured by a Doppler probe on the posterior and the anterior tibial arteries of each foot and on the brachial artery of each arm. The artery is first located. The cuff is inflated beyond the disappearance of the acoustic signal. The reappearance of the signal during deflation corresponds to the systolic pressure. The ABI of a leg is calculated by dividing the highest ankle pressure of this leg by the highest arm pressure. An ABI less than 0.90 or equal affirms the presence of a PAD. An ABI greater than or equal to 1.40 testifies of an arterial incompressibility, often due to medial calcinosis induced by diabetes or chronic kidney disease. In this case, it is necessary to evaluate distal perfusion by measuring toe pressure. 20 to 30% of patients with PAD have diabetes. The diagnosis of PAD in diabetic patients is challenging. First, in these patients, the symptoms of PAD may be absent due to the presence of peripheral neuropathy. Furthermore, the accuracy of ABI is lower in patients with diabetes because of medial calcinosis. ABI is often overestimated. This is why in diabetic patients, the toe brachial index TBI at rest is preferred to the ABI for the diagnosis of PAD. The transcutaneous oxygen pressure measurement, TCPO2, may also be helpful, but these diagnostic tools are not necessarily available everywhere. To measure TBI, laser Doppler is a reference, but plethysmographic techniques are also used, but their performance is inferior. An ABI less than 0.90 is diagnostic for PAD. If the ABI is normal or high, we have to use TBI. A TBI less than 0.70 is diagnostic for PAD, and a toe pressure absolute value less than or equal to 30 mm of mercury is a diagnostic for critical limb ischemia. The treadmill test, usually using straightness protocol at a speed of 3 km per hour and a 10% slope, is an excellent tool for objective functional assessment and unmasking moderate stenosis. It is also helpful when the ischemic origin of limb pain is uncertain. The test is stopped when the patient is unable to walk further because of pain, defining maximal walking distance. A post-exercise ankle systolic pressure decrease of more than 30 mm of mercury or a post-exercise ABI decrease of more than 20% are diagnostic for PAD. Transcutaneous exercise oximetry can also be used for patients with atypical claudication, gluteal or thigh claudication. CLI is at present defined by the presence of a chronic ischemic rest pain or trophic disorders for at least 15 days, associated with a systolic blood pressure of less than 50 mm of mercury at the ankle or 30 mm of mercury at the toe, or a TCPO2 less than 30 mm of mercury. Patients with CLI are at very high risk of amputation at 6 months. More recently, Somerset's study shows that a plantar acceleration time greater than 225 milliseconds is strongly correlated with CLI. Duplex ultrasound, DUS, is often the first step in the vascular workup, both for screening and diagnosis. DUS is used to detect and localize vascular lesions and quantify their extent and severity through velocity criteria. If a surgical revascularization is planned, another more aggressive and expensive imaging is performed, like CTA or angio-MRA. As a conclusion, we can say that clinical examination is important but not sufficient to perform an objective diagnosis of PAD. The diagnosis is based at present on the measurement of the ankle brachial index. The diabetic patient is very challenging because of possible lack of symptoms and the presence of medial calcinosis. The use of toe brachial index is recommended. Thank you very much for your attention.
And with this, we congratulate Dr. Thomas James, and we move forward with the mentors, starting from Professor Josnan. It's my true honor and pleasure to introduce him. So Matt, I know that you have your slides ready. So if you'd like to share your screen and unmute yourself.
Okay.
We can see it perfectly. Just go slideshow.
Okay, thank you. Thank you, Sergio. Oops, sorry. Okay. I would like to thank Thomas for this excellent presentation, which gives us guidelines that every vascular physician should know about the diagnosis of peripheral arterial disease. I'm going to complete this presentation by a short talk about a concept that is completely complementary to what has just been said and which is essential in our practice, the analysis of the Doppler waveform in the peripheral arterial disease. It's important to know that the Doppler waveform, or at least its analysis, is another tool that is used to diagnose peripheral arterial disease, and it has already been recommended by the guidelines of learned societies, such as the American Heart Association, European Society of Cardiology, European Society of Vascular Surgery, and etc. All international recommendations agree that the ankle brachial index is the reference technique for diagnosis PAD. But in certain populations, such as diabetics, renal insufficiency patients, and the elderly, the ankle brachial index may be falsely normal. And in this case, and given the learning difficulties, Doppler flow assessment may appear to be interesting. This is a normal verosymmetric morphotypes, present different aspects, also called modulations, described as follow, ascending branch and its rise time, descending branch and its fall time, a negative diastolic component, a positive diastolic rebound, and a return to baseline. In addition to these different phases, we can analyze a spectral window too. The alteration of the verosymmetric signal includes successively, according to the severity of the arterial lesion, disappearance of the positive diastolic rebound, disappearance of the negative diastolic component, increase in the downstroke time of the descending branch, collapse of systolic velocities, etc. The Doppler waveform is subject to an analysis in which the subjectivity of each individual can be taken into account. For this reason, it was necessary to create classification in order to harmonize the whole of its remarks. And the first classification was made in 1974, by Descott and Catignolle. This is this classification in 4 tips, exactly 5 tips with the first, which is a normal tip. The second classification was created in 2005 by Sprung-Canal in 4 stages. And at least finally, more recently, the French College of Teachers of Vascular Medicine in 2017 suggested a new classification, simplified classification of Simbonnet. This is this classification. This classification for us in France is recommended for French physicians for the analysis of arterial flows. And this is the reference of the publication of this guideline in the Journal des Maladies Vasculaires. Another publication dating from this year, from 2021, and published in the Journal of Clinical Medicine, compared all this classification, the 3 classification I told you about. And this is the conclusion of the authors. The author concludes on the basis of medical interpretation, but also about teaching that the classification of Simbonnet provides superior categorization compared to other classification. And it's a very important conclusion. And for me to conclude, I encourage you to read this article, but also to use a classification to allow you to harmonize your practices, but both medically, but in terms too of transmission to future doctor. I think that the harmonization of all our practice will indeed lead to an optimal follow-up of our patient. Thank you.
And we deeply thank you, Matt, for the wonderful contribution. So please stop sharing so we can advance with the other mentor, who is indeed Professor Narayan Sriram from Singapore. Always a brilliant contribution. So here is his contribution for the day. Ram, if you want to share your screen, perfect. I can see that, and go slideshow. Can you hear us, Ram? Unmute yourself. If not, we have the video ready, as you prefer. You have to unmute yourself and then go slideshow. Now we can hear you. Okay.
Okay, coming up. Trust me, coming up.
I trust you. I know your quality.
I thank Sergio and the Weaven Foundation for this opportunity to speak about diagnosis.
So,
can you hear me? Okay,
yeah,
I'm going to go live rather than play the video. Is that okay?
The idea is that you speak over the slides. If not, we can play the video from our end.
And I will go live. Okay, so I'm going to take a slightly different approach to the diagnosis of peripheral arterial disease, because for many trainees, it appears that it is a question of preoperative diagnosis and no further. What is important in peripheral arterial disease is to understand that there's a large component of intraoperative diagnosis as well. And the new tool of intravascular ultrasound has made a big difference to how we approach this. If this slide will move.
In peripheral arterial disease.
I think you have a delay because you are using the subtitles. So don't worry, Ram. We will have you live for the questions later on. So stop sharing, please, and I will go on our side. So please stop sharing, and we just enjoy your video. Okay, and we will get back to you so we can enjoy once again your new hairstyle in this picture and then your presentation here.
I thank Sergio and the Weaven Foundation for this opportunity to speak about diagnosis in peripheral arterial disease. I will take a slightly different tone in intraoperative diagnosis with intravascular ultrasound, which is something, in my view, that all trainees must begin to learn. There are many decisions to be made. Some are made before the diagnosis of a PAD, and some diagnostic decisions are made on the operating table. We do need to know whether disease severity justifies intervention, what is the best form of intervention, and what sort of lesion should be intervened in what way. And IVUS does allow us to measure the vessel size. It tells us about the pathology within the lumen and what is the composition of a plaque if it's present, what interventional length should be used depending on the length of the lesion, what device and how to place it accurately, and reduces the amount of contrast that is used during the procedure. Of course, there are many options for endovascular intervention now in peripheral arteries, from balloon angioplasties, angioplasty stents, drug-coated balloons, atherectomies, and so on, and many other combinations of these. But the evidence for using an IVUS in peripheral arterial interventions comes secondarily from many studies to do with the Gore-Viabahn endoprosthesis, the Supera stent. There was a direct study evaluating the intravascular ultrasound use in femoropopliteal stenting. And there have been other studies that have looked at adventitial cuts post-atherectomy, as well as a definitive AR study where IVUS was used as one of the outcome measures. The Viper trial gave us a fairly direct message that oversizing a stent to the size of the artery is a bad idea, with a significant drop in patency rates, because oversized stents lead to a fairly significant response from the artery in terms of endothelial hyperplasia. The Supera trial, which was assessed, superb trial, which assessed the Supera stent, also suggested that oversizing is not a very good idea. The IVUS study that was directly used for femoropopliteal lesions also showed that patency rates are better if IVUS is used during the procedure. The Utopia study showed that IVUS can predict adventitial cuts after an atherectomy with a very high degree of accuracy, and these adventitial cuts bring down the patency rates as well as have increased complication rates. The definitive AR, the study which assessed DCB with an atherectomy versus a DCB alone, also had similar findings. So the IVUS also allows us to assess plaque morphology, and with virtual histology as well as chromoflow now available, we can make an assessment of what type of lesion requires what type of intervention. The role of IVUS, of course, is for sizing. It shows that angiography alone is not enough in peripheral arterial disease, and it allows us to fine-tune our decision-making on devices. I will quickly show the case of a 57-year-old American who used to be very fit and a competitive cyclist who presented with sudden onset short distance claudication for 2 months. This is his ultrasound, and the arrow on the right picture shows you the dissection flap in the iliac artery. He had bilateral common iliac artery dissections. The IVUS here shows the dissection with the IVUS catheter inside the true lumen, and the chromoflow demonstrates the false lumen as well. This still picture shows you the true lumen and false lumen, something that IVUS can assess extremely well, so you don't stent the wrong lumen. This still IVUS picture shows the normal common iliac artery on the left picture and the increasing fibrosis on the right. And you can now see the onion skin appearance of a typical iliac artery endofibrosis, which was the lesion that led to the dissection, something that is seen in competitive cyclists, multiple layers of an onion skin. So in summary, the role of IVUS is evolving, but it is something that trainees must learn if planning to treat peripheral arterial disease in the future, and new technologies like chromoflow and virtual histology will only add to the diagnostic armamentarium. Thank you for the opportunity.
And we thank you, Ram, for this brilliant contribution. And now, as always, for our format, we started the World Scientific Round, where we have 4 different top experts from 4 different continents, starting from Germany with Professor Hohmann, who is, of course, in the operating room in this moment with an emergency, so we'll enjoy his question, and then the mentors and resident will give us the answer.
Hello and good afternoon, everybody. Many thanks to Sergio, Professor Bottini, and Dr. Shi for inviting me to this great webinar. I would like to thank Dr. Jam and Dr. Jossin for their very instructive presentations. My first question goes to Dr. Jam. Additional to a performed clinical examination, ABI, and a duplex ultrasound, which diagnostic tool would you recommend as guidance for an optimal planning of the treatment, CTA or MRA as the next step? And the next question goes to Dr. Jossin, and I would like to kindly ask him, should we adapt our therapeutic approach to the findings of the Doppler flow assessment in diabetic patients, for example, with help of the classification, or wouldn't it be easier to go with a cross-sectional imaging like CTA or MRA? Thank you very much.
And with this, we deeply thank Professor Hohmann, and we go all the way to France, and we give the mic to our resident, Thomas.
Hello, everyone. Hello, Dr. Hohmann, and thank you very much for your very interesting question. To my mind, CTA is the best tool for planning of the treatment for proximal lesions because CTA gives better spatial resolution images than MRA. CTA allows better analysis of arterial walls, including calcification, but also the interior of metallic stents. However, this is much more irradiating examination than MRA, and there are contraindications to iodine injection, such as kidney failure or allergies, which are very rare with MRA. This is very problematic, for example, for diabetic patients with kidney failure, and MRA or arteriography should be used immediately. Furthermore, MRA is better for analyzing distal arteriopathy because it shows the blood flow in these thin arteries without being bothered by calcifications.
That is good. And now we go all the way to your mentor, Professor Josnan, Matt.
Yes, to follow up on Thomas' question, to explain this notion well, the distal arterial network of certain patients, such as said Dr. Moon, and thank you for your question, as a diabetic or renal insufficiency patients, are very complicated to examine by Doppler ultrasound. The main problem is that in this patient, the arteries have a lot of calcification, and this calcification will generate acoustic shadow and will injure or even prevent the ultrasound analysis, both from morphological point of view and from the flow point of view. It is therefore preferable to use other imaging techniques such as CTA or MRA, as said Thomas. Concerning the difference between CTA or MRA, I cannot answer you exactly in detail. Perhaps one of you will be able to do so, but it's often preferable in France to use MRI for distal exploration, particularly at the level of the legs in this patient, because the visualization on CTA will be more limited.
Thank you so much. And we keep on flying around the world, and it will be Professor Bottini introducing the next top expert. Oscar?
Let me introduce Professor Nikos Lavropoulos, a brother of mine that has been supporting our inter-university project since the very beginning. Nikos.
Here is his question or comment.
Greetings from New York. Hello, everyone. Dr. Thomas Zams talked about the diagnosis of PAD using primarily physiologic testing and briefly mentioned the imaging techniques. It is clear that physiologic testing using waveforms and pressures before and after exercise is cheap, cost-effective, and reliable way to diagnose PAD. It has been adapted worldwide, but is also underused. More challenging has been the evaluation of regional perfusion, based on which clinical outcomes of interventions can be determined, and it could be a matter of discussion. Dr. Matthew Jocelyn discussed the analysis of Doppler waveforms in PAD. He described the normal waveform and presented the different classifications on the disease severity. It would be nice to use the waveform patterns on follow-up of interventions in a more wide manner and promote research in the area to further refine interventions. Thank you so much.
We thank so much, Nikos, for all the educational contribution he does. And Matt, would you have a comment on this?
Yes, thank you, Professor Agopoulos. Indeed, monitoring the evolution of arterial disease by waveform is a valuable tool. It is in fact one of these points that the Saint-Bonnet classification has been put forward compared to the other classifications, because it allows, by multiplying the categorizations, to have more stages and therefore both the diagnosis and the follow-up. This is extremely interesting because of if a patient deteriorates, the flow will deteriorate. However, it is also possible, on the contrary, for a patient who follows his treatment and respects physical activity that will be requested to see an improvement in the hemodynamics, and this will be felt in the waveform with a better modulation of the later. This is certainly much more striking when measuring the ankle brachial index, which will also be able to show an improvement or deterioration according to the vascular states. But as Thomas said, it has some limits. I think that additional studies will be necessary to be able to support all this, because indeed the correlation is, for my part, extremely important.
Thank you so much. And now we fly all the way to Central America. I wish it was me introducing him. He's a dear friend, but it will be Professor Chi introducing the next expert.
Yeah, next we have a good friend to the VUN Foundation, Dr. Andreas Marin from the Dominican Republic, who actually teamwork with the VUN Foundation for the last humanitarian mission.
And here is his comment and question.
Hello, this is a question for Dr. Thomas. Do you think it's enough with the clinical examination and Doppler ultrasound to take a decision for the intervention in PAD? Or do you prefer to perform a DSA or CT scan before the procedure to take the decision? Thank you.
We already covered a little bit of this, but if you want to dive more in the topic, Thomas.
Hello, Dr. Marin, and thank you for this question. I think that we have to realize a CTA or MRA before scheduled arterial surgery in order to research for non-visualized lesions with DUS, because CTA is less operator dependent than DUS, and CTA displays a roadmap of the vascularization. So you can talk about the surgery with colleagues while we look at the images, for example, to plan surgery, and also to evaluate if it's possible to realize an endovascular surgery or not by evaluating upstream and downstream status.
Thank you so much. And now we conclude the world round in Japan with the comment from Professor Takashi Yamake from Tokyo.
Thank you for your nice presentations. These presentations are educational and informative for the graduating resident. Asymptomatic PAD accounts for approximately 20 to 60% of all PAD cases, according to the reports from population-based primary care setting. The typical prognosis of the peripheral arterial lesions begins with intermittent claudication and eventually leads to severe CLI. So it is important to detect patients with intermittent claudication at the early stage and test for PAD. But nowadays, we see so many patients with CLI without pre-onset intermittent claudications. Some studies have shown that diabetic neuropathy is responsible for the absence of intermittent claudication. So my question is, do you have any algorithm to detect non-intermittent claudication patients or vascular lab testing? Again, thank you for your excellent presentation.
And we pass now the mic to Professor Sriram, Vin Diesel, Narayan.
Thanks very much, Sergio. Well, there's a very Asian problem that, unlike in the West, almost 90% of peripheral arterial disease in Asia is related to diabetes. And Professor Takehiro made a very good comment that intermittent claudication is not a classical symptom in the diabetic because of the sensory neuropathy. So what is our algorithm to follow and diagnose these? This is where a screening program becomes key. The presence of sensory neuropathy and the routine measurement of toe pressures, not just measurement of toe pressures if the ankle pressure is low, is standard practice for us. I'm quite excited by many of the newer imaging technologies like Indocyan in green with SPY, laser speckle with PEDRA, and thermography that allow us to see the changing perfusion long before the waveforms begin to change and you start seeing obvious anatomical changes on a CT or MR. So our current algorithm is a screening program, sensory neuropathy, toe pressure measurement, which is regular. We usually do a thermography in our clinic, and if we see any of these suggest developing peripheral arterial disease, then it's a Doppler. And then if it looks like it requires intervention, it will need a CT or an MR, depending on if it's proximal or distal disease. Usually MR is our preferred modality because of the amount of calcification and the small vessel disease that diabetes involves.
Thank you so much, Ram. And indeed, this is perfectly in line with the question that we are receiving from the audience, because as the audience knows, they can make questions in the question and answer box in whatever language, and also with the comment Professor Taha just made in the chat. And Wasila is writing, this is a great discussion. I would add that ultrasound is an operator-dependent diagnostic modality. With adjusting the machine parameters, color gain, velocity scale, we could surpass the effect of heavily calcified arteries. And this is in line with the audience question that is coming from Obiudun Lamine. And this colleague is writing, which is the preferred diagnostic modality for lower limbs PAD, CTA or ultrasound? So we understand that in reality that the question is a little bit more complex than what it looks like. And I would open the floor for discussion, since now we have some minutes for open discussion. And since I see that our honorary chair, Professor Golovinsky, is still with us, and I deeply thank him for this, I would take the honor of having him here for some comments and insights from the master. So Peter.
It's a great discussion. Just a brief comment that I would encourage the residents to read the global vascular guidelines published in 2019, accepted by all major vascular societies, that replaces the term CLI with chronic limb-threatening ischemia. And I think that's an important change that, time is short to discuss, but it is something that we need to consider, because it looks like the new universally accepted term for advanced PAD is CLTI.
Thank you so much. Any comment, Raman, on this?
Well, my only comment was that the question suggested, would you prefer a Doppler or duplex, or would you prefer a CT? There are three components to making a diagnosis. One is, what is the hemodynamic and functional degree of the ischemia? One is what is the anatomical location of the lesion, and one is what is the best possible intervention and an investigation to direct that. So it is important that we do not treat these in exclusion. It is important that we understand that the duplex with the waveform, the CT or the MR for the anatomy, as well as understanding the degree of calcification and plaque change to decide the intervention are not exclusive to each other, one or the other, but all need to be used together in order to make the most appropriate diagnosis. Of course, you move from the least invasive to the most invasive technique.
Thank you so much, Ram. And I would take these last minutes to ask to all the panels what you think about near-infrared retroscopy. We placed a study here at the University of Ferrara where we were like pointing out how in reality with ABI we're not really able to detect the patients in terms of severity. And for example, using compression in ABI that were low, we had a biggest benefit with the highest CF classes and lowest ABIs, understanding that from the near-infrared retroscopy. We would have never been able to understand that with the ultrasound. Do you see any room for these extra available devices or not in the everyday clinic? Ram or whoever wants to jump on this.
Well, I certainly do, with laser speckle spectroscopy coming in, as well as tomography and indocyanine and green imaging. There is a reason for that. We were looking at more proximal imaging, like with DSA or with CT or MR, because that was the extent to which we could intervene. It was very difficult to do a bypass into a toe artery. And as far as even those who were doing dorsal pedis or postertibial artery bypasses were considered to have a special skill. But that has changed with modern intervention techniques. Retrograde dorsal pedis puncture is almost normal now to try and revascularize vessels. Routinely doing plantar arch revascularization is going on. So as we are revascularizing more and more distally and more zones in the foot, the need for imaging or some form of diagnostics that looks at perfusion in the zones of the foot or various aspects of the foot or the wound-related artery, these have become important. And here the more anatomical imaging tends to fail. And you need functional imaging in the form of spectroscopy or tomography, but we are yet to standardize objective values for this, but I'm sure it will happen over time.
Thank you so much, Ram and Peter and all the stellar faculty. And now we move to the second part of today's initiative. And indeed, it is my huge honor and pleasure to introduce the other colleague who served as a mentor with me, Professor Raffetto from Harvard, no need of introduction for Joe. But a new entry that is a wonderful new entry is Oscar Ucles, a wonderful resident. We will be talking about peripheral arterial and venous disease management, all vascular specialists should know. From Spain, here is Oscar talking live. Unmute yourself and share your screen.
Okay.
Perfect. Now go slideshow. Good to go.
Okay. Hello, everyone. My name is Oscar Ucles. First of all, I would like to thank you, Sergio, for the invitation to take part in this great project. So today I will tell you about PAD and CVD management. There is no conflict of interest regarding this talk. The presentation is divided in 3 parts. I will begin with epidemiology, then I will look at pathophysiology and risk factors, and finally I will talk about treatment. Regarding epidemiology, the topic is particularly important considering CVD and PAD are more frequently associated than usually thought. A correlation too often forgotten was already reported in this 1987 paper. This study showed that the absence of pulses or diminished ankle brachial index was detected in an 11.4% and 21% of a sample of 827 patients suffering from CVD. Subsequent studies have reported similar data with a prevalence of arterial disease ranging between 13 and 16% in patients with venous leg ulcers. This study published in 2020 found that 21% of patients with PAD examined with MR angiography showed signs of coexisting CVD, and that CVD increased 1.7 times the risk to have a clinical diagnosis of a stage 4 PAD. Particularly interesting was that only 18% of these patients were previously diagnosed of CVD, showing that this disease is usually underdiagnosed. and higher body mass index and diabetes were significantly associated with CVD. Here I bring you another publication from 2016 in which severe forms of CVD were strongly associated with PAD by up to 27% of cases. Higher body mass index and hypertension were the only risk factors that showed a significant association with both disorders. Let's now turn to pathophysiology and risk factors. This publication showed a high prevalence of deep venous incompetence, reduced venous filling time, and loss of arteriovenous response among a sample of 75 diabetic patients. These alterations could all lead to lymphedema and subsequent symptoms, including ulcers. Therefore, controlling CVD in these patients would help improve symptoms, prevent ulcer appearance, and promote ulcer healing. Thus, we should have a high level of suspicion in order to correctly identify these mixed patients. ABI and duplex ultrasound should be routinely performed to diagnose both disorders, and a complete assessment of risk factors for arterial and venous disease is also an essential tool and needs to be done to complete a correct diagnosis. Okay, so regarding treatment, let's start with pharmacology. First, let me talk briefly about matrix metalloproteinases. These enzymes play an important role in maintaining vein wall structure and function. Increased hydrostatic pressure in varicose veins secondary to valve dysfunction is thought to induce hypoxia factors and MMPs inducers, thus leading to extracellular matrix degradation in atrophic regions and vascular smooth muscle cells proliferation in hypertrophic regions. In relation to PAD, atherosclerosis is an inflammatory process in which MMP's activity is tampered. Loss of intraplaque regulation increases MMP's production derived from smooth muscle cells and macrophages, leading to the degradation of the matrix-rich fibrous cap of an atherosclerotic lesion and its eventual ulceration. Likewise, matrix metalloproteinases increased activity leads to arterial narrowing following angioplasty, either constrictive remodeling or intimal hyperplasia. An indirect evidence of common pathophysiology ways in PAD and CVD can be found in the action of drugs acting on reducing MMPs, MMPs levels, like sulodexide. This is a mixture of glycosaminoglycans that indeed demonstrated anti-inflammatory and endothelial protection activity in both the venous and arterial district. Regarding CVD, this study showed the benefits of sulodexide in venous ulcer healing and in the reduction of venous thromboembolism recurrence. In relation to PAD, sulodexide showed a significant improvement of pain, tissue oxygenation, and walking distance in claudicant patients. These findings were confirmed in a recent meta-analysis showing how this drug acts on both arterial and venous sites, reducing odds of all-cause mortality, cardiovascular mortality, myocardial infarction, and venous thromboembolism, suggesting then a common path in both disorders. Statins have also shown beneficial effects on arterial and venous disease. They are recommended in all patients with PAD as they have demonstrated a significant reduction in all-cause mortality and cardiovascular events. Regarding CVD, this trial from 2009 found that statins significantly reduce the occurrence of symptomatic venous thromboembolism due to its anti-inflammatory properties. Let's talk now briefly about graduated compression stockings. Compression therapy in CVD is the mainstay of treatment. In patients suffering from both PAD and CVD, it has shown positive effects both in toe pressure and ejection fraction in this publication from 2012. Similar results were found in another study from 2020 with significantly increase in toe pressure and improvement of CVD symptoms in patients with concomitant pathologies. In relation to PAD, compression therapy is indicated for use in case of concomitant CVD or mixed ulcers as previously exposed. It is also helpful to diminish edema among diabetic patients without any negative impact on low extremity circulation. Furthermore, it is suitable for treatment of low extremity edema following surgical intervention, preventing bone complications. However, we should keep in mind that compression therapy should be properly prescribed. This study from 2017 showed that 31% of pressure injuries in intensive care units were due to GCS. Besides this, GCS can lead to ischemic lesions in the treatment of deep venous thrombosis, thus increasing the risk of amputation. Therefore, I reiterate the potential benefit of compression in specific arterial patients following the prescription of an expert healthcare professional, and I invite you to enjoy the next webinar talk dedicated to this topic. Related to surgery, in this study from 2017, arterial revascularization was always performed when in patients with CVD C6 diagnosis when ABI was lower than 0.5 or when ABI was between 0.5 and 0.85 if pain control or ulcer healing failed to improve after 3 months with modified compression therapy. Results showed that arterial revascularization helps to improve management of these ulcers, but healing rates were not as good as in patients with no associated PAD. This paper from 2008 found that venous reflux surgery performed in patients suffering from CVD-C6 with and without concomitant PAD showed no significant differences regarding healing rates. So this surgery could help improve management of mixed ulcers, although PAD is also present. And lastly, a brief comment about exercise. Exercise has shown positive outcomes in CVD patients with significant higher rates of ulcer healing in patients with lesions that perform 10 foot dorsiflexions per hour. In addition, patients with PAD who did exercise to mild moderate pain achieved significant better results than those who did not practice exercise in terms of peak of oxygen, pain-free, and total walking distance. However, a joint program is missing. Lastly, to conclude, we should have a high level of suspicion because both disorders are more frequently associated than usually thought. A careful evaluation of these patients is essential, performing a correct assessment of risk factors, being high body mass index, hypertension, and diabetes of particular relevance. Ankle brachial index and duplex ultrasound should also be correctly done in order to diagnose both disorders. And regarding treatment, different strategies should be implemented. Medical treatment plays an important role, and drugs acting on both arterial and venous sites, such as sulodexide and statins, suggest indirect common pathophysiology pathways. GCS also depicts a good treatment, but properly prescribed. Arterial and venous surgery could add a potential synergy in the management of these patients, and exercise represents a very useful tool to improve symptoms in patients suffering from both disorders. Thank you for your attention.
With this, I deeply congratulate Oscar, asking him to stop sharing so we can proceed. But before proceeding, I really want to congratulate him once again. It has been truly a pleasure co-working with him and with Professor Raffetto. Now it's time for hot topics and unmet needs. So I will get started. And since the great project is indeed about mentors and residents, I'd like to get started quoting a big mentor from the venous world, Van der Stricht, who was used to say that we should know the history so to avoid wasting our time trying to open doors that were already open by others. These are my conflicts of interest. While I think it's pretty interesting to see that in reality, the combination of chronic venous disease and peripheral arterial disease has been known for quite a long time. This is an Italian publication from 1957 that is already reporting how often PAD presents concomitant venous disease. If we go on reading, we see that they are writing that there is an association between PAD and CVD that have been known even before this publication. For example, in 1878, with Winnie Water reporting about that, and with Cornell pointing out how 40% of the PAD patients were actually presenting also chronic venous disease. Another interesting publication from the past, I think, is this one from 1995, reporting the so-called Finland paradox, for which they identified a protective factor for varicose veins in diabetes patients. Now, it's interesting to notice how the answer to this paradox might have been found just a few days ago, this publication reporting how metformin, which is one of the few drugs available at the time of the previous publication for diabetic patients, actually has anti-inflammatory properties that are reducing the risk of varicose veins. Now, we know from this other publication, 2018, that the venous inflammation is increasing the risk of DVTs. And it's interesting to notice from the same publication how this venous inflammation is also significantly increasing the risk of PAD. So we understand that there might be a common path somewhere in there, in this flow translation into a biochemical signal. And this translation, this biosignaling, is usually happening because of antennas we have along the endothelium lining that are sensitive to the variations of the flow. And in particular, for example, in this case with the glycocalyx, as per this publication, that is reporting as it can be an innovative treatment target for both veins and arteries. Now, we know from this other very interesting publication from Professor Parsh and Lee that whenever we are talking about the veins, we also want to talk about lymphatics. And I could not be more thrilled than now in presenting to you for the very first time, up to my knowledge, the first available picture of a human endothelial cell reporting the presence of a glycocalyx on the lymphatics and not on the veins. So I look forward for giving more data of these investigations we are running together also with Professor Raffetto by electron microscopy. Because indeed we know that the Starling principle cannot be the only factor explaining the filtration at the capillary levels. It has been clearly demonstrated already by other publications like this one showing that the lymph composition does not overlap the one of plasma. And in terms of glycocalyx, indeed, we have a common antenna whose thickness can be responsible in its alteration for LDL deposits in the arterial side. So further hot topics for investigations in the future that in reality have already in the past some hints, like from this publication that is putting in correlation the venous medial thickening and the arterial impairment in delayed ischemic foot ulcers healing, as per this one, showing how venous hypertension is a risk factor for delayed ischemic ulcer healing again. And moving to the very last publication, since we started with all publications, another interesting report showing us in a larger population how fixing the venous inflammation is actually reducing the thrombotic risk, but also the PAD risk. Just touching the topic of compression, since next week we will focus on that, I think it is time to stop easy publications like this one, simply stating that ABI is the cutoff value to choose on our practice. We understand that edema is leading to alteration of oxygen diffusion and perfusion, and also to an increased exudation that, of course, is not beneficial for our arterial patients, for which a contraindication, sometimes a good indication is, we could say, and this is actually a quote from Professor Parsh when he was talking about compression in arterial patients. Of course, first of all, we have to assess properly our patients before eventually recommending compression, as Oscar Ukeles was reporting, but this is a publication from the University of Ferrara that is showing indeed that we can have a benefit in terms of tissue perfusion and oxygenation, even in lower ABI, of course, with proper assessment of the case. And indeed, we were having better results in terms of near-infrared retroscopy data, having patients with higher CF and lower ABI. Interestingly, as Oscar said, 13% of those who obtained greater benefits would have not utilized compression on the basis of just the ABI that was low. Again, compression is like a drug in terms of benefits, and we have, of course, also the same thing for the harmful part, so we must be cautious in the prescription with the proper knowledge, so to give proper benefits to our patients, breaking down the wall that is separating the investigation of the arterial and of the venous wall. With this, I conclude, and I pass the mic to Professor Raffetto, who is having Wi-Fi issues, so he will be with us for the discussion live, and we enjoy now his presentation.
Hi, this is Joseph Raffetto, and I really want to congratulate Oscar Ukeles for a wonderful presentation, review of the similarities between venous leg ulcers and peripheral arterial disease, as well as my good friend and colleague and brother, Sergio Giannazzini, for his review and wonderful presentation of the pathophysiology and some of the new findings of the glycocalyx. So I'm kind of taking a different approach. Certainly there's many associations, but really these are two different diseases. But there's definitely where you have sort of the three circles and you intersect the VLU and the PAD where they come together. And certainly you can have disease that is combined. And we know this happens. But what are some of the areas that require further studies? Well, as mentioned both in Dr. Euclid and Professor Genesini's talks, there are common pathways, certainly the inflammatory pathway with the leukocyte, the adhesion molecules, metalloproteases. These are expressed. Certainly there is endothelial function and dysfunction, and this is similar between venous and arterial pathologies, but there are also many, many differences in mechanisms and also in various molecular pathways. They do have similar shared risk factors, and therefore this has to be evaluated in patients that present with venous leg ulcers, meaning that you have to evaluate the arterial system because of shared risk factors such as obesity, diabetes, smoking, and hypertension. What are the structural differences and similarities of the endothelium and the glycocalyx? I think this is a fundamental question that we really need better information. It is one of the knowledge gaps. Certainly we know that the glycocalyx plays an extremely important role in the mechanical transduction, sensing also shear stress, and there's a number of glycans and syndicans that are very important in this signal transduction. But we need further information to see what the similarities and differences are between arterial and venous diseases. Obviously, the mechanism of drugs such as sulodexide and statins is sort of some common shared ground, but there's also many differences between veins and arteries. I've done some experimentation in the basic science lab, and I've actually shown that there are significant differences in how sulodexide acts on arteries and veins. Really, a big question is when should we revascularize venous leg ulcers in patients that have concomitant peripheral arterial disease? There are some guidelines, but are these strict guidelines? No, you'll see the grade data is quite low. It's 2C. So it's we need better data is what it really means. And think about it, location of venous leg ulcer and the pathophysiology compared to that of an arterial ulcer, they're clearly different where these occur. So I want to focus sort of on compression because I think that's one of the mainstays of venous leg ulcers. And in office basics, really normal compression can be applied if the ankle brachial index is greater than 0.8. However, we got to start modifying our compression treatment, and we have to monitor these patients if the absolute systolic blood pressure is greater than 60 millimeters of mercury and the digital pressure is greater than 30 millimeters of mercury, or an ABI of 0.5 and 0.8, you can apply compression that usually is either a short stretch bandage or 4-layer bandage. But absolute pressures correlate better with tissue perfusion. Now we have to be careful when these pressures actually decrease. Here's an interesting study that by Bill Marston. It's an older study from 1999, and they found that 15 to 20% of venous leg ulcers will have associated arterial insufficiency. Arterial insufficiency in this study was defined as an ABI less than 0.8. In this study, 50% had arterial insufficiency. Risk factors were independently affecting the venous leg ulcer healing time, and these were initial ulcer size as well as arterial insufficiency. They recommended a modified compression of 3 layers for individuals that had concomitant arterial insufficiency, and they provided a pressure of about 25 to 30 at the ankle. This actually shows their graphic demonstrating the effect of arterial insufficiency on venous leg ulcer healing. At 10 weeks, if you had negative arterial insufficiency, you healed 63% of venous leg ulcers, and if you had arterial insufficiency, only 25%. But eventually, 85% of venous leg ulcers with arterial insufficiency heal with 3-layer bandaging. So they do heal. The consequence of compression in patients with peripheral arterial disease is that 33% of patients with venous leg ulcer and compression will have new wounds and gangrene. So any patient with an absolute systolic blood pressure of less than 60 millimeters of mercury or a digital pressure of less than 30 millimeters of mercury should not undergo compression. And any external compression should not exceed the perfusion pressure measured. And this is where the 60-30 rule applies. And you can modify the compression with 3 layers versus 4 layers if you have lower pressures to prevent serious complications as well as limb loss. Recommendations for arterial revascularization is an ABI less than 0.5. If no improvement in healing after 4 weeks of compression and the ankle brachial index is less than 0.8, you can consider revascularization. And obviously, if they have massive tissue loss, exposed tendons and muscle, you want to revascularize. And if they present with critical limb ischemia, you want to revascularize. And when not to compress, in these guidelines from 2014 from the SVS AVF Guidelines Committee, in venous leg ulcers, in patients with venous leg ulcers with underlying arterial disease, we do not suggest compression bandages or stockings if the ankle brachial index is less than 0.5 or less, or if an absolute ankle pressure is less than 60 millimeters of mercury.
And with this, we go back live. We have Joe with us. Raffetto, Joe, if you can unmute yourself. Perfect. Here we are. Nice to see you. Joe, can you hear us?
Oh, how are you doing?
Oh, okay, all is perfect. So now let's move forward with the word round, starting from Dr. D'Amata from Brazil, a great expert on the topic, particularly of compression. So Eduardo, would you like to make your question?
Thank you. Thank you, Sergio. Congratulations for the presentation, Oscar, Sergio, and Professor Raffetto. And I have three important considerations about the treatment of venous ulcers, CAP-C6, associated with PAD. When we talk about modified compression therapy, as mentioned in the presentation, it means inelastic compression with interface pressure between 30 to 40 millimeters of mercury, not only graduated compression stockings. And as Professor Raffetto explained us, when we talk about ABPI between 0.5 and 0.8, it's more important that ABPI is the absolute systolic ankle pressure and toe pressure, because ABPI is a ratio between ankle and toe and the systemic pressure. When we can have a 0.5 ABPI and systolic pressure lesser than 60, and our inelastic interface pressure will be higher than the protective pressure, and we can have problems. And the last but not least, I would like to talk about exercise that is so important to the treatment of venous ulcers. We have to focus in resisted exercise, not only walking or not only the movement, because we have to get muscles hypertrophy to improve the ejection fraction and to improve the action of the inelastic compression in the treatment of ulcers associated with PAD. We will certainly have better results and faster healing of the ulcers. Thank you very much.
Thank you so much, Eduardo. Oscar, would you like to comment on this? Unmute yourself. No, well, there are two. You can both comment, but that was for Ukles, but we will have two comments.
It was three, okay.
We start with the new generation, then we go with Oscar too. So,
okay. So first of all, thank you, Dr. D'Amata. I really appreciate your considerations. I completely agree regarding the inelastic and short stretch bandage used in arterial patients. My concern about this is the fact that they are extremely operator dependent, as demonstrated by PROTS, showing that only 10% of health professionals were able to reach a proper pressure. Considering the available data on feasibility and on efficacy of proper GCS use in arterial patients, and considering that their application is not operator dependent, my hope is that more and more awareness will be developed in the topic among health and non-health professionals. Then regarding your second consideration, it is true that beyond ankle brachial index, the absolute systolic pressure at ankle level greater than 60 millimeter is essential to apply this modified compression therapy, as it correlates better with the tissue perfusion, and also toe pressure could also add a potential benefit in diabetic patients or in patients suffering from chronic kidney disease, as this measure is less influenced by the severe media sclerosis. And lastly, yes, in relation to exercise, I also great appreciate your comment. Even if I am not aware of data showing that the real target to be in the muscle hypertrophy. I think that the fundamental aspect to be considered here is the adapted practice of exercise rather than random physical activity. And this is true for both disorders, pointing out the importance of always producing standardized and reproducible data in order to advance in evidence-based science. Thank you.
Thank you so much, Oscar, and thank you so much, Eduardo. I really invite everybody to enjoy the activities of Eduardo D'Amata in Brazil. They are doing great work in terms of compression in particular. And Oscar, Professor Bottini, would you like to make a comment before introducing the next expert?
No. We now travel to Central America to listen our close friends, Latin American leader and president of the Salvador Society of Phlebology and Lymphology, Dr. Luis Rodriguez.
Gracias, Sergio, Willy, Oscar, por la invitación a esta excelente iniciativa educativa. Felicito al doctor Oscar de España por tener claro que las patologías venosas, arteriales y linfáticas solo tienen una separación académica, más nunca una separación en nuestra práctica clínica. Por eso, indiferentemente, si nuestra principal práctica es angiología, flebología o la cirugía vascular, todos estamos obligados a manejar los principios que usted mencionó de epidemiología, evaluación clínica y ultrasonográfica, y por supuesto los tratamientos médicos y quirúrgicos para las condiciones vasculares mixtas con mayor grado de recomendación. Le quisiera preguntar, ¿cuál sería su conducta en un paciente que usted tiene pruebas serológicas en rangos normales de su colesterol, HDL, LDL? Es un paciente, sea 4A6, reflujo venoso que usted documenta, pero además usted identifica que tiene muchas placas ateromatosas, circulación con la arterial complementaria, en ultrasonido Doppler. Su índice rasotoyo está arriba de 0.6. Usted prescribiría en este momento estatinas y antiagregantes plaquetarios antes, durante y posterior al tratamiento venoso que usted decida practicar. Doctor, coméntenos, por favor.
Oscar?
Yes, thank you, Dr. Rodriguez, for your interesting question. Firstly, and in relation to statins, as previously exposed in my presentation, statins are recommended in all patients with PAD, regardless of the LDL levels, as they help to reduce all-cause mortality and cardiovascular events. In venous district, statins have demonstrated a significant reduction in the occurrence or in the appearance of symptomatic venous thromboembolism, but not an improvement in symptoms of patients suffering from severe forms of CVD. Therefore, in the case in the patient you mentioned in this question, I would prescribe him statins, but due to the concomitant PAD. And regarding the antiplatelet therapy, there is still not enough evidence to support its use in patients suffering from CVD. And in relation to PAD, the single antiplatelet, long-term single antiplatelet therapy is recommended only in symptomatic patients. Therefore, in this particular case, I would prescribe concomitant antiplatelet therapy only in case this patient suffering from CVD, C4, C6 shows clinical signs of peripheral artery disease, such as clinical claudication or rest pain. And eventually, I would also like to say a brief comment. As I previously showed in my talk, common pathophysiological ways can be found in both diseases, and I think that future research should focus on endothelial biosignaling in order to develop new drugs acting in both disorders at the same time.
Very complete answer, Oscar. Joe, would you like to add something to this? I think Joe has some issues with the Wi-Fi. Can you hear us, Joe Raffetto? If not, we will move forward and we'll go back to Joe when he's unfrozen. And we now fly on the way to Russia. So it will be Professor Joe. Was I hearing you, Joe? No. So let's.
I'm here.
Okay. So would you like to make any comment on this?
I think Oscar really summed it up very well. Thank you again for that question, Professor Rodriguez. And I think I'll just add that.
No, connection is very poor, Joe. If you want to try switching off the video.
We really have to balance the risk versus benefit, and we need to know the number needed to treat to reduction of VT with the statin therapy. The problem, though, is there are no other parameters that are arterial disease, such as MI, stroke, and all-cause mortality. So, it gets, especially with the question posed when you have an API greater than 0.6, so it could be anything from 0.6 to normal. And do you put all individuals on statins and to prevent the VTE risk, and especially if you're undergoing procedures, and if they have minimal cardiovascular morbidity and they don't have in general very symptomatic PAD, we have to use some caution there because the data is not very strong, as Oscar pointed out. I will tell you, there was one paper that I remember a long time ago was published in Circulation about antiplatelet therapy and ulcer healing, but it was a very small trial. I've never seen it reproduced. I think it was 20 patients in each group versus placebo, but actually it was published in Circulation showing a benefit of aspirin. I don't know the mechanism of that, but certainly we need better data to really understand whether we can actually cross.
You're breaking up again, Joe. But we understood the message. So let's move forward now.
Prescribe to individuals with PBD. Higher risk. For the question in the comments.
Thank you so much. Now we fly all the way to Russia. So it will be Willie presenting the next top expert.
So we have a good friend to the VWIN Foundation, a leading figure from Russia, Professor Shadakov.
And talking about flying, he's actually stuck at the airport, which is bad news, but also good news because it means that we are going back to flying at least. And he sent me the question. And the question is, glycocalyx is a well-known layer of macromolecules attached to the endothelial cell membrane. Destruction of the glycocalyx may be one of the first signs of endothelial dysfunction or injury that leads to formation of nanoparticles of glycocalyx that may have various biological effects. Do you think that by studying nanoparticles of glycocalyx today, we would promote early diagnostics of chronic venous disease and arterial disease, which may lead up to novel early pharmacotherapy? Now, this is a topic of great interest for us because indeed we consider that as a sort of antenna that can answer to the different mechanical stimuli, both in the arterial, in the venous side, and as I was mentioning, thanks also to the great collaboration with Professor Raffetto on the lymphatic side, for which I hope soon we will be able to deliver you the full data of this interesting aspect that, of course, is the translation of physics forces into biochemical forces. A thing that, up to my knowledge in the literature, is still also missing is the communication between the different layers. So not just blood and endothelium, but also endothelium and muscle cells. So that will be also another interesting area to look at. Joe, would you like to comment further on this?
Sure, thank you, Sergio. Professor Shadakov, thank you for the question. It's a very interesting one. And, the glycocalyx is a very important structure. And we know that there's a number of molecules that has a great interest to both Sergio, myself, and a number of other individuals that want to study this area. But certainly, looking for the mark for disease potentially at risk of developing the diseases of the C. That's really a number of factors that can destroy the glycocalyx. We've known for a while that metalloproteases are expressed in patients with CVD, and we know that metalloproteases actually act on the glycocalyx by actually damaging syndicans, and glypicans, which are a major component of the glycosaminoglycan with the protoglycan. One other aspect that I think is important is, and in studying this, I think one area that we may be able to look into is measure this sphingosine 1-phosphate. It's an extremely important part of the glycocalyx that is expressed that actually stabilizes the glycocalyx, inhibits some of the actions by metalloproteases and heparinase, and could be a measurable, I've never seen a study that actually has measured this in patients with CVD, but could actually be measured, and it's S1P, sphingosine 1-phosphate, potentially could actually be an indicator if it's elevated. Why would it be elevated? And likely because it's trying to repair the damage to the glycocalyx. So that it's actually protective. It has a lot of other functions, such as cell viability, with also migration of cells and differentiation of cells and replication. So it's a quite important molecule that potentially could be one of the targets that we could look at in patients with CVD and potentially early diagnosis of individuals at risk for progression.
And,
thanks, Sergio.
I thank you so much again for all the teamwork in education and science. And now we fly all the way to Italy to another great figure, a wonderful representative of my country, Professor Paolo Valle from the Italian Association of Phlebology. Paolo, are you with us? I was seeing him before. Yes, here he is.
Okay. Good afternoon, everyone. Thanks for the invitation. And these three interesting reports that show how close is the relationship between CVD and PAD, and further study are needed. I appreciated Sergio's focus on compression therapy that clearly improves perfusion through the reduction of edema. Unluckily, the old concept is still present that venous stasis is good for patients with PAD. Greeting to all and good luck.
And with this, we thank Paolo for his comment, and for the sake of time, we move forward, also deeply thanking all of the top experts, including Professor Golovinsky and Professor Bishara, who have answered already in the question and answer box to great figure like Professor Cabeza, who is with us today, and also it was also again Cabezas making the other question. So now we move toward the end of the initiative, and we go all the way to an important part that is the one of the audience. As we mentioned before, we really look forward for engaging more and more with the audience, offering them the opportunity to come on stage, being selected through their evidence-based comment sent in the days before the webinar. And it is my huge pleasure to introduce Dr. Larissa Paez Lopez from Paraguay, from the Asunción Central Hospital, and she has been selected with their evidence-based comment on intermittent pneumatic compression. So Larissa, would you like to go live and share your screen?
Yes.
Here we are, we can see it, just go slideshow. Larissa, can you hear us? Yes.
So greetings to everyone. Yes. I'm Dr. Larissa Paez, Head of Supervision of Asunción, Paraguay, and I would like to start by saying thank you for this opportunity and to congratulate the organization of the great project for this endeavor. I will be talking about intermittent pneumatic compression and its role for venous and arterial diseases. First of all, we have its use for treating venous leg ulcers. Cochrane database systemic review of 2014 used 9 randomized controlled trials, and the authors' conclusions were that IPC may increase healing compared with no compression. It isn't clear whether it can be used instead of compression bandages. When added to compression bandages, rapid IPC was better than slow IPC in one trial, and further trials are required to determine the reliability of current evidence. On the other hand, we have its use for lymphedema. A systemic review of 2019 mentions different modes of compression, and it was concluded that all types of timing and sleeve configuration are effective. And in terms of duration and pressure of IPC application, there's a trend towards lower and shorter treatment times compared with earlier studies. So now the effect of high pressure IPC for the treatment of peripheral arterial disease and critical limb ischemia in patients without a surgical option. In theory, by compressing all the tissues below the knee, there's a venous pressure drop to nearly zero and increase the arterial flow. So in this prospective control study, subjects were randomized into two treatment groups, one with high pressure IPC and the other one with an exercise regime. The study was designed to measure as the primary endpoint, as the time to maximally tolerated claudication pain. So as a result, the 4 and 8 mark week, there was a percentage change that became significantly different at the 16-week mark. So in conclusion, the high pressure IPC significantly improved PWT, reduced resting time, and improved healing rates, physical function, and bodily pain. This study further supports that high pressure IPC is safe and effective and should be considered for patients who are not candidates for endovascular or surgical procedures. And furthermore, high pressure IPC offers an excellent alternative for the ischemia symptoms. So in conclusion, for improper IPC, for venous ulcers, lymphedema, peripheral arterial disease, a potential common benefit found in edema control, venous arterial reduction, and its fibrinolytic effect. And as well, there's a further need for an increased grade of evidence to identify proper dosing and timing of this measure.
With this, we congratulate Dr. Paez. There were like some technical glitches, but we didn't want to stop you because indeed it's a pleasure to have you live joining the stage from the audience. And it's my pleasure now to introduce you to Professor Bishara, who needs no introduction. He's one of the pillars of the LATAF bridge between Latin America and Africa. So he's the perfect person to make a comment / question to you and your mentor, Professor Firizzola. Rashad?
Congratulations, Dr. Larissa Paez. Congratulations, Dr. Larissa Paez. I really enjoyed your presentation. You summarized very well the use of IPC in 3 important areas, venous leg ulcers, lymphedema, and peripheral arterial disease. Your presentation was clear and concise with good support from the literature. I have a comment though. The use of IPC for prophylaxis against venous thromboembolism is an important application that was not mentioned in your presentation. I guess that's because of time restrictions. And I have a question. What do you recommend as precautions in case of use of IPC in the treatment of venous leg ulcers with concomitant peripheral arterial disease? Thank you, Sergio, for the great opportunity to participate in this distinguished educational activity.
Thanks so much to you, Rashad, and we address the question to both Professor Firizzola and Larissa. So you can take the mic, Larissa or Roberto.
Greeting from Paraguay. It's an honor for us to participate in this international meeting. And we are excited for this participation. We hope to participate. We will participate in another in the future. There are no, we don't found papers that evaluated this specific population with PID and venous disease, but the intermittent pneumatic compression have evidence of benefit in both disease. There are benefits in the hemodynamic effects with the increase of the venous outflow, the arterial flow, and we also have benefit in the endothelium function. And I think we can use this method of treatment in both of in patients with have both of disease.
Thank you so much, Dr. Firizzola, and congratulations once again to Larissa. It has been a pleasure. I'm sure we'll have many other opportunities to meet each other online and in person. Now it's time to go with the honorary chair take-home messages. We will close with a wonderful person, a wonderful professional, Professor Wasila Taha from Egypt, the other pillar of the LATAF bridge. So Wasila, I guess you want to go live. If see you are with us, so please.
Thank
go.
you. Thank you so much for the introduction. And I please confirm that you are seeing my slide. Okay, perfect. Thanks from Cairo to all of you, experts, mentors, residents, and surely audience. Thank you, Sergio, Oscar, Willie, for the huge opportunity to introduce great project. It's a top quality experts in one of the best examples between mentors and residents, and in a very insightful way. Now to the final remarks. I have been challenged to summarize all these great discussions and perfect lectures in 3 minutes, but I will try to do my best. First part with the PAD diagnosis, Dr. Thomas Jam, he did a great job, and as well the great mentors, Professor Mathieu Josselin and Professor Ram. For the bedside non-invasive investigations, he highlighted very much that the clinical examination is very important in terms of edema, as well as the excessive wounds and palpation of the pedal pulses, ABI and TPI, the toe pressure index, they are very important, the bedside investigations. But with this scientist in 1903, Meckenberg, he the first described the calcific medial sclerosis, which really described a very important challenge for the ABI and TPI, and rendering this indices falsely elevated mainly in the diabetic patients. So we have to be really aware of this and very vigilant for this. Another diagnostic modalities, CTA, as mentioned before, MRA and the IVUS and the ultrasound, we will go to see the benefit and the disadvantage of each one. For the CTA, whenever we go distally, the sensitivity and specificity for the CT and geography, it drops. And the vast majority of our PAD patients, they are diabetic patients with tibial artery disease, which is this is the really morphology and the distribution of the pathology in diabetic patients. So it's not the best modality to image the patients with diabetic foot. In addition, the harm of the contrast would go up to 150 millimeter in the dose. It would be very harmful with these fragile patients with kidney function test. And for the IVUS, Professor Ram, he did add this diagnostic during the interventions, and he highlighted the benefit of such tool, IVUS. Despite its cost effectiveness, it's of high cost, but it's very useful whenever you are dealing with the aorta or aortoiliac, specifically in dissections lesions. Coming for the ultrasound, and we were honored by the comment of the huge figure and the giant of the ultrasound, Professor Nikos Lapropoulos. And I will add here that the detailed arterial map provided by the duplex, it's really very important. It showed the underlying causative lesions in terms of size, caliber of the native artery, and the length of the lesions. And very importantly, this is the sole modality which provides you the hemodynamic impact of the lesion. In 2004, in our team, we conducted a study, and it's validated with the distal velocities, validated with the pressures, and we conclude that there is the thresholds for the critical limb ischemia with the 25 centimeter per second. So with this study, we did classify and stratify the degree of ischemia, mild and moderate and severe, and with the severe threshold below 25 centimeter per second. Coming to the second great part, the PAD and CVT management, Dr. Oscar Ulk, you did a great job, Dr. Oscar, and of course the two great mentors, Professor Sergio Giannisini and Professor Joseph Raffetto. Oscar, you did really cover all the aspects in terms of epidemiology and the common risk factors between arterial and venous disease and the pharmacological effect with solid oxide, and not only the venous side, but also on the arterial side, which really go to the significant reduction of the pain of the claudication and the role of statins with the reduction of the cardiovascular events. And it did highlight a very important, and I do echo and second your terms in terms of we lack the exercise in our protocol for our patients post-operative, post-revascularization. Thank you to highlight this point. Coming to Professor Sergio Giannisini, fantastic presentation as always, Sergio, and you did take us in a long journey from the old, long and diving the long history of association between PAD and CVD from the old literature up to the newly recent, and highlighted very well the glycocalyx in PED and CVD and its sensitivity to the different pathological flows, the arterial flow, the venous flow, and even the lymphatic flow, with a unique photo with the glycocalyx in lymphatics. Professor Joseph Raffetto did a fantastic job and highlighted and undermined there is still gaps to be fulfilled and unmet needs in terms of the endothelial level as well as the macro pathways levels, and also the correlation between the effect of the arterial insufficiency and the venous leg ulcerations healing, and when to do compression and when don't do compression. This is very important that Professor Raffetto, he highlighted or pointed to the pressure itself and not to the index, and this is well highlighted and elaborated last week by Professor Fedor Lurie as well. So the threshold here for the pressure 60 millimeter, and for the toe or the distal pressure 30 millimeter. Again, he highlighted the indication of revascularization, and I would like to add just one indication more on the top of the list, the crippling claudication pain in active productive patient. So this is based on the last guidelines, appropriate use for revascularization for claudication. Dr. Larissa, congratulations, you did a great job despite all the technical, sometimes it was interrupted signals, but the overall work, it was outstanding. Congratulations, dear. And I would like to end by this slide. We feel that we win meetings, they are really our personal meetings, and this is what I call success. Congratulations, and thank you so much for the huge opportunity.
Thank you so much to you, Wasila, for always being the best example that teamwork wins championships rather than individual games. So thank you so much. And we go now indeed with the ending, talking about teamwork and family. Oscar and Willie, if you like to say a last goodbye until the next week. Oscar?
Thank you for participating in this educational proposal. See you again next Saturday.
And Willie?
See you next Saturday. Have a good weekend, guys.
And I will take this chance then to invite all the residents to submit their abstracts to the next meeting of Oscar that will be in Buenos Aires, where the board will gather together next September. I'd like to take this chance to deeply thank all the stellar faculty who has been involved today. I deeply thank once again Mary for the unbiased support, and once again for having believed and supported the initiative of having residents in the first line. Next weekend we will be together on Sunday rather than Saturday, always 2 p.m. GMT. And once again, I'd like to deeply thank all the giants involved today, particularly also Professor Grovinsky, who has been with us until the end. I really like this quote that is saying the greatest good you can do for another is not just to share your riches, but to reveal to him or her his or her own. So thank you so much to all the giants who joined us today, and we look forward for being together next Sunday. Thank you so much, and congratulations to the residents who did a great, actually, job.
Great.
Thank you so much.
Thank you. Bye-bye. Bye-bye. Ciao.